Mark Kris from Memorial Sloan Kettering, commenting today on a paper and on a editorial that recently appeared in the Journal of Thoracic Oncology. The paper was from Dr. de Leeuw, last author Dr. Dingemans, and it talked about the weight gain that occurs in patients on alectinib. They were able to show that there was a gain of weight in a substantial proportion of patients, and actually about 10% of the patients gained over 10 kilograms. And I think many of us that have used that drug have seen that and know that it's really been a problem for some patients. In the accompanying editorial, Camidge and Taormina point out that we're in a brave new world of toxicity, that now because people are on checkpoint inhibitors, people are on TKIs for a very long period of time, we have to think about long-term toxicities. And I'm not talking about cumulative toxicity. I'm talking about persistent toxicity of the drug. They pointed to that paper about weight gain, but what about even the more common toxicities, things like rash and diarrhea? Please remember that OnePlus diarrhea is up to 3 more bowel movements per day. So think about it. If you're a twice-a-day bowel movement kind of person, you could have 5 bowel movements a day for years and only have 1+ toxicity. I know as oncologists we say, oh, the toxicity is only 1+. Well, what about 1+ rash? I must say I was a little shocked when I actually read the data from the what is 1+ acneiform rash from the CTCAE, and it's papules or pustules covering less than 10% of the body surface area, which may or may not be associated with symptoms of pruritus and tenderness. So think about it. If you have 1+ toxicity from a TKI, that could mean constant rash with pruritus and tenderness for years. So you need to pay attention to these chronic toxicities. And even though it is, quotes, 1+, when you take that 1+ and stretch it out into years, it's really, really a problem. The bowel movements are a particular problem. At the lung meeting I recently attended, one of the patient advocates who was attending there pointed out how this 1+ toxicity is really disruptive to persons, knowing that they're going to have frequent bowel movements beyond what they normally do, and it really changes their life. So from the oncologist standpoint, what to do? Number one, ask the patient. More than just how many times, how it affects their life. And if you find out people aren't living the life they want, you really need to think about what to do. The other thing that you need to do is to think about lowering the dose of these drugs. Generally, the doses are too high. I'll point to a paper that recently appeared in JTO of Japanese investigators that looked at afatinib, and they compared a dose of 40, the standard dose, to 20, and they found in their population of patients tremendous improvement in adverse effects, but no change in overall outcomes. And I think the data is there too. By the way, in that paper about the weight loss with alectinib, half the patients had a dose reduction. So think about a dose reduction for those side effects that are lifestyle changing. So kudos to the authors of the alectinib paper. Kudos to Drs. Taormina and Camidge for reminding us that 1+ toxicity over many, many years is difficult, in some ways much harder than serious toxicity that lasts a week. Pay attention to it, try to deal with it by ameliorating the side effects with whatever local measures we can. But when we can't, think about dose reductions. And I think the literature shows that most patients have dose reductions anyway. And the literature that's out there comparing lower doses shows very little change in overall outcomes.